So this video is about ILD, interstitial lung disease, which is very important for UG. So for ILD, definition is like ILD is kind of a misnomer, okay, because you don't know the exact information, exact definition of the interstitium. So proper definition of the ILD is very important. It will tell about presentation and some of the investigation findings. So ILD is, that is interstitial lung disease. So interstitium is connective tissue that holds the lung together. So interstitium is alveolar, it is around the alveoli, vascular around the blood vessels, pulmonary and bronchial, all that, and the axillary interstitium which connects the chest and lungs. So alveoli plus all three interstitium makes the parenchyma of the lungs. So ILD is not just the interstitium lung disease, it is diffused parenchymal lung fibrosis. So fibrosis of interstitium, all these three, as well as of alveoli. This is ILD. So instead of remembering ILD, remember it as diffused parenchymal lung fibrosis. So it is fibrosis of alveoli and interstitium and all these three, which is mediated by TGF beta and PDGF. So classification of ILD is not must, but you should know a basic, like this is basically etiology of ILD. So you can remember this as this table. So most common is idiopathic interstitial pneumonia, and in that you have to remember these two because CT findings are different for these two, and presentation will be different on CT. So most common is idiopathic interstitial pneumonia, and in that there is one usual interstitial pneumonia which is UIP, and then there is non-specific interstitial pneumonia which is NSIP. Then second most common are autoimmune disease associated ILDs, which are rheumatoid arthritis, SLE, Sjogren's syndrome and systemic sclerosis. Then sarcoidosis associated ILD, and there is hypersensitivity pneumonitis associated ILD. These two must be just RMY, these two. Okay. So now comes to clinical presentation. Patient will be more than 50. The hallmark feature will be dyspnea and exertion. So dyspnea and exertion is mostly a feature of cardiac disease because the heart will not be able to pump. There will be hypoxemia. The body will try to compensate by increasing heart rate and increase respiratory rate to compensate the hypoxemia, but the patient won't be able to breathe that much properly because of the pulmonary edema caused by ventricle failure. So dyspnea exertion is mostly cardiac feature, but it is also present here. So now we have to understand why dyspnea exertion is present in this respiratory disease, which is usually a cardiac feature. So here what is happening is the lung parenchyma is fibrosed. So increased ERP due to fibrosis, static and dynamic compliance is decreased. That is, lung is not that much wanting to inflate. So vital capacity and TLC decrease. So we have only supply out for normal work. Okay, when the person starts to do some exertional work, there is not much oxygen, so hypoxia occurs. So now body tries to counter it by increasing respiratory rate to correct the hypoxia, but due to fibrosis the RPS is so much increase and the lung compliance is so much decrease that patient is not able to breathe properly. That is when the dyspnea occurs. So hallmark is dyspnea on exertion only. Whereas in other respiratory conditions like pneumonia and ARDS and other conditions, dyspnea is without exertion also. Then there is cough, dry non-productive cough, that is no, because there is no infective pathology and no diurnal variation, like as in different conditions like asthma, COPD and TB. So signs is clubbing, then velcro crackles. Okay, so on auscultation velcro crackles, which is bilateral, that is on the both side, because interstitial fibrosis occurring on the both lungs, not like some kind of bronchiectasis or TB which may be unilateral, or some foreign body which may have gone to one side, or like pneumonia which is mostly on the dependent bronchopulmonary segment, that is right basal. So here crackles are bilateral and bibasal, that is basal means in the lower lobe, and not wearing with cuff. These are called velcro ankles. So velcro belt is the belt like that just stuck on its own, like come on the handbags, like we, it's like a tape, like there's a rough hairy part and we just stuck another part over that, which is, and then we, when we open it, it's makes sound like zzz. So for investigations, we will start with chest x-ray. So chest x-ray is not diagnostic, it is only suggestive of ILD, but still we will start with this. And it also, it won't be able to tell which type of ILD is there. So finding will be bilateral, bibasal and reticular infiltrates, like there will be net-like opacities in the lower lobes, bibasal, and on the both side bilateral. So then move to PFT. We'll do spirometry. On spirometry, FVC will be decreased because ARP is too much increased and the compliance is too much decreased. The lung is not compliant to inflation, so FVC is decreased. FEV1 is decreased because see, in ILD is a restrictive disease. So in restrictive disease, expiration is not like inhibited. Expiration is even supported by the increased ARP, but here FEV1 will be decreased because the FVC is so much decreased, and as we know that FEV1 is 80% of the FVC. So if like FVC is decreased from 5 liter to 3 liter, so obviously 80% of 3 liter, that is FEV1, will be less than the normal person, which will be 80% of 5 liter. And FEV1 upon FVC ratio will be normal or either increased, because the decrease in the FVC is more than the decrease in the FEV1. So it can be normal or maybe increased. Now DLCO is obviously will be decreased because DLCO is diffusion across lung membrane of carbon monoxide. So diffusion will be obviously decreased because there is fibrosis of the interstitium. Then third investigation, which will be HRCT, thorax, which is diagnostic and is investigation of choice. So just first see how a normal lung appears on the CT. So in normal lungs, just see on the Google images. So normal lung, there will be like lung parenchyma will appear homogeneous black, and in that bronchus will appear dark black because bronchus has more air than the lung parenchyma, so it will appear like dark black tubule like this. Lung parenchyma will appear dark like this. Vessels will appear like maybe white dots or tubules, like the vertical vessels will appear as tubules and the horizontal vessels will appear as tubules and will appear white because they have blood in them. And now HRCT findings in the ILD will be in both these types. Most common is our idiopathic interstitial pneumonia, which has two further subtypes. So in both these there will be bilateral and bibasal infiltrates. Okay, so how will they appear? So in UIP, and we know fibrosis appears will white. So in UIP there is loss. The characteristic feature of UIP is there is loss of lung architecture, but in NSIP there is no loss of lung architecture. Now there will be reticular shadows, like the fibrosis band will appear like this, net-like pattern. Okay, also will be there here also. Now honeycombing. So what is honeycombing is like the fibrosis will form like this cyst in the lung parenchyma, and this cyst will be walled off. So these cysts are not now available. This cyst area is not available for ventilation. So this is honeycombing with architectural loss of lung parenchyma, because this cyst will not be able for ventilation, as these cysts unavailable for ventilation. Okay, honeycombing is not present in the NSIP. Then there is traction bronchiectasis. So this is not bronchiectasis disease, that is different findings. This is traction bronchiectasis. What here occurs is that the bronchus, that the surrounding fibrous tissue is fibrosing, so it will pull the bronchus along with it, so which will cause the architectural distortion. Here this is in NSIP, this is absent. So just see Google images of each of these here. So these two are the hallmarks of honeycombing and traction bronchiectasis, hallmarks of UIP, and for NSIP hallmark is ground glass opacities. So what are ground glass opacities? So basically we see the homogeneous, like normally we the lung parenchyma is homogeneous black on CT. Okay, but here what we will see is like we have put some uncleaned glass over the homogeneous lung parenchyma. That kind of opacity is called ground glass opacity. Okay, this is mostly seen in COVID, and also NSIP is finding in COVID also. So then come to treatment. So UIP is a bad prognosis because there is no effective treatment, and for NSIP the steroids are effective, and also immunosuppressants, in which the MMF, that is mycophenolate mofetil, it is the best one. We can also use cyclophosphamide and azathioprine. Now come to treatment of ILD on average, like on overview, and this should must by UG. Specific for these types, it's not must, but this must be remembered. So first there is anti-PDGF and anti-VEGF, which is nintedanib. So it is most commonly given in fibrosis caused by COVID-19 post-COVID patients to decrease or to stop the further progression of the fibrosis due to COVID. Dose is 300 mg per day. Diarrhea is a very common ADR. Then the anti-TGF beta is pirfenidone, and TGF beta is the more important fibrotic cause. So you have to remember this pirfenidone. You cannot leave this. Then comes the steroid and immunosuppressant sensitive ILD disease, like our NSIP and all the autoimmune associated ILDs. They will also be steroid and immunosuppressant sensitive. So we can also give them in NSIP or these conditions. So this is ILD. The most important thing is this definition, that is ILD is kind of a misnomer. It is diffuse parenchymal fibrosis. Then type, have an overview of type because this is etiology. Then for signs there will be distinct evaluation, this pathology, how is occurring, cough, okay, velcro crackles in signs. Then remember the 6-hour chest X-ray is not diagnostic, it will just suggestive of ILD. What will be findings on this? This finding. PFT is just findings of a simple restrictive disease. Then an HRCT, remember this difference table for this UIP and NSIP, and treatment has to be just smug up. So here you remember this TGF beta is more important for fibrosis. Okay, done with ILD.